Hey everybody, it's Monday, not Friday, but Monday, so this is the Doctor is in live with TOA. I'm Gray Stahlman, I'm your host. This is Dr. Robert Thompson.
Thanks for having me.
Thank you. Dr. Thompson is a foot and ankle specialist, primarily, right?
Correct.
Here down in Murfreesboro, and we're going to continue on our Murfreesboro road show. Dr. Thompson wanted to talk a little bit about Achilles tendons and all that kind of stuff that goes on with the Achilles tendon. I think that's a good topic for us to talk about. As always with our conversations, while we are both fellowship trained orthopedic spine surgeons right now, we're not your orthopedic surgeons. I said spine surgeons, sorry. We are both fellowship trained orthopedic surgeons, but we're not your orthopedic surgeons. So if you have a medical problem, if it pertains to what we're talking about today or anything else orthopedic, go to TOA.com, find out about TOA, find out about our locations, our doctors, what we offer, and get appropriate help by people who are not just here entertaining you. Okay. Anyway, without further ado, Robbie Thompson, Gray Stahlman, thank you for being here. It's good to see you.
All right, thanks for having me. So we're just going to talk some about Achilles tendon injuries and Achilles tendon problems. So they're not all just ruptures, but probably the more common thing that we hear is what is a classic story for an Achilles tendon rupture. And so people who follow sports or even just trying to stay fit and healthy, you're going to have some discomfort from the Achilles from time to time. And probably the most common story is usually male between 30 and 50, and the most common example again is playing basketball, where usually people come in and they say, I went up for a shot and I came down and I turned around and I said, who kicked me? And I look behind me, no one's there. And so people say, no one kicked you. And then usually that's the most classic story for it. And then people come in and usually there's some bruising and some swelling, and then we look at the pattern of it and then we make a decision on how to progress and how to treat and go from there.
So other than the pain, what other kind of problems with an injury, whether it's a complete rupture or partial rupture, can people complain about when their Achilles is no longer functioning correctly?
Sure, probably the most common one is, besides pain, and really the pain is pretty temporary. Most people don't have as much pain as you would think. Maybe 2 or 3 days really at most of really painful focus right in the back, and they think they get over it and they say, well, I just thought it was a sprain. Sometimes they're hard to pick up on. Probably the other thing would be weakness of push off if they're trying to push forward or jump and they can't do that. And that's probably the most common secondary finding besides pain for that.
So what do you do with a torn Achilles, a ruptured Achilles?
Well, the most important thing is recognition, because it can be challenging if it's not identified initially to try to treat that. And you have options either way. Not all Achilles equal surgery. It really just depends on patient-specific treatment in terms of the patient attached to that Achilles and the family attached to that patient, as I like to say as well, in terms of what you're trying to get back to. But it's really something about front-loading risk versus back-loading risk and options for what to do. And a non-surgically treated Achilles is not the same as an ignored Achilles, not at all. So most people think that it's going to speed them up. It does not routinely. There's some evidence that it can help you get back to work maybe a little bit faster from a predictability standpoint, but overall most people do pretty well regardless of what they choose, as long as they follow it appropriately. But it typically just depends on the location of the rupture, and MRI is often useful to try to help figure out location, and that can have a implication for how we treat it, and then also what people do and other risk factors as well.
So let's assume that you're going to treat injury non-surgically. What does that involve for the patient?
Sure. Well, first we have a long conversation, just helping me get to know you and what your goals are, what you're trying to get back to. And I tell people all the time, I don't need a perfect Achilles for me to play bad golf. I do that anyway. But it's something that we just have a long conversation and making sure we spend plenty of time discussing expectations and goals. And then typically we talk more about casting for the first 2 weeks, just having the foot pointed down, and then bringing people back. That just lets the fibers settle down, let the inflammation settle down, and hopefully let things start growing back together. And then we just talk more about the recuperation, and everyone's about the same right about 2 weeks out, either 2 weeks from the initiation of this non-surgical, or what we call a functional rehabilitation program, or 2 weeks post-operative from surgery where we get the stitches out and we go from there.
So then 2 weeks in a cast to start with.
Correct.
And then what's the progress? How long does it take for people to get healed and then I'm sorry, and then functionally back to where they want to be.
Sure. Well, I would say overall, this is, as a kind of disclaimer, this is just my particular protocol. So everyone is different with it, and I tell people often there's more than one correct way to approach a problem. So for me, what works best in my hands is that functional rehabilitation program, 2 weeks in a cast with your foot pointing down, and then having a boot, and we want to start working on motion. Tendons want to move. That actually helps them as they heal. And so we have people in some different heel lifts taking tension off, and then gradually increasing pressure over a 4-week period. And then around 6 weeks, we have people at that point have been doing full weight bearing for about a week, and then we gradually start stretching it back out by removing one of those heel lifts, and then I'll take you to the 10-week mark, and physical therapy starts then. So we really just let the dust settle, let everything start trying to knit back together, and then we go from there around the 10-week mark. And then in terms of people's overall progress, I try to break things up, as I say, into bite-sized chunks. What can we get you to that 2-week mark and get you through it? Because often, it's so overwhelming to get lost in the details of long-term. But I would say overall, I tell people, give me 3 months, and we'll have you in regular shoes. And most people are ready to start running and jumping between 5 and 6 months out. And that's true with or without surgery. But that's just purely talking from the physical standpoint. The psychological component is the other thing. People often are having to deal with the fact that their body betrayed them. This often is their first big injury, and they're trying to get fit, trying to be active, and playing basketball. I hear that often.
They're doing the right things,
right?
And
Exactly.
they still get hurt.
Exactly. And they say, "What am I supposed to do?" We just say, "Well, it's nothing you did. It's just something that happens, and just recognizing it and treating you and going from there."
So when you see a patient, and what would make you lean toward advising surgery versus a non-surgical approach? I know you said that it's a little bit of a give and take as far as what the patient wants, what you advise, but what would make you lean towards surgery?
Sure, like we said, just really trying to get to know what the patient wants and what their goals are. So overall, I say, what do you want to get back to? What is important to you? And if they say, well, I don't really do much, I'd say, well, we can still treat you surgically if you like, from a predictability, maybe a little bit more security standpoint. We'll get to re-rupture rates just in a minute, but overall, if they say, what I really want is to be able to push off with as much strength and power, and that's probably the most important thing that would push me more towards surgery. Say, just predictability. If you're saying you really want to be able to run, want to be able to jump and do those things, but not everyone's like that, and it's at the end of the day, it's a choice, and it's a good option either way. And then there's other options too if it doesn't work as well, or if their expectations aren't there, and it can be challenging to deal with those, just like anything. But it's just about having the lengthy discussion about goals and risks and benefits for that.
And then, like you said, basically surgical recovery is almost identical to non-surgical recovery as far as restoration of function, restoration of mobility, return to activities in a timing kind of thing.
Well, from the time standpoint, it's the same timeline.
Yeah.
In terms of outcomes for that, like I said, probably surgery is a little bit more predictable. By no means is surgery guarantee of return to get back to what you want to do, but I tell people I'll do everything I can to get you back as close to perfect as I can. It's not a guarantee I'll get there. The only thing I can guarantee is I'll do the best I can for you.
What are the risks of surgery? Are there specific risks to surgery in that area that people need to think about?
Sure. There's common risk for any kind of orthopedic procedure, just like any other surgery as well. We take people through rather than just the normal risks. I always tell people risks are pain, bleeding, infection, damage to nerves and blood vessels, need for additional procedures, risk to the anesthesia. Things like stroke, heart attack, death, blood clots, they're there. We just talk about them, we just have to recognize them. Probably specific to Achilles tendon injuries, the things that we have to tell people about are, number one, maybe not getting back to the same level of function that people were wanting to. Also, Achilles tendons are notorious for two things in particular. One is going to be wound healing complications, just because of the skin around that area. It's very thin. Even people big or small, there's really not much tissue there. And then also the risk of blood clots as well. And then in terms of other risks too, we talk about things like re-rupture rates as well for those. So people often will come in with the expectations and they say, I got an Achilles, I've got to have surgery. And to some degree it really startles them when I say, you've got options for what to do. And that means that's a longer conversation, but that's my job, to take you through it and let you know the pros and the cons and the risks and rewards for those things. A classic Achilles tendon non-surgical treatment, and keeping in mind that these treatments have evolved for the years. And some of my mentors when I was training would tell me when they started, it would be long leg cast up to your hip with the knee flexed at 90 and your foot pointing all the way down for 3 months, which is just crazy for us to think about those things as well. Probably similar to how in spine,
barbaric, yeah.
Right, talking about full body casting as well for those things as well.
Yeah.
But everything evolves with times, and it's something that now we just move forward with, but the traditional re-rupture rate was quoted often as about 20%, meaning 1 out of every 5 people could re-rupture their Achilles.
And that was with surgery or without?
That was without surgery.
Okay.
And that's the classic non-surgical treatment, whether it be casting primarily, and again, not this functional rehabilitation program that's really been the last maybe 15 to 20 years.
So just really strict immobilization, then let them go.
Right, exactly. And so, you know, there's a lot more information in terms of the success rates for non-surgical treatment as well. And now I tell people that, you know, as far as I know, in terms of, unless there's something else that has come out, probably about maybe 4 to 5%. So instead of 1 out of every 5, now you're talking 1 out of every 20 that can re-rupture. And so if you talk about surgical repair, the re-rupture rates are probably about 1 to 2%. Now that's still double. 1 to 2 is half that of 4 to 5, but still we're not talking a huge number of absolute numbers of ruptures, but it just depends on how you want to view that. And so the surgical repair probably gives a little bit more of a secure repair and allows for earlier range of motion and probably more predictable push-off strength because we can set the tension a little bit better. So that's how it works. And I describe often if you're trying to pull or tow something with a rope that's really elastic or has a lot of slack, you can't pull this much power. And that's how the Achilles tendon works. You have to set the tension appropriately.
Well, it's interesting that you talk about how things have evolved and changed, particularly in the functional recovery after injury, because it's the same in spine. We used to keep people down for a week in a 6-inch long incision. Now they go home the same day with a 2-inch long incision, and we found that letting them go back to activities after a ruptured disc is actually better for them than keeping them down.
Sure.
And so you know, it's not we're not tricking biology. We're just learning more about biology. Right. So speaking of that, the big buzzword these days is regenerative medicine, buzzwords, PRP, stem cells, anything like that. People ask all the time, are these things the latest and greatest things? Is this something that you would use in this practice? What's your knowledge of these biologic treatments for a tendon injury like this?
Sure, you know, and that's something too that we're learning more constantly, you know, every day. So I think overall, the main thing is, I imagine, and you may have already had these conversations before, is just the reproducibility. Just, you know, if you're getting stem cells from one place versus another one, PRP from one, there's just a lot of variability to it. And so we really want to try to maintain what we call that biological environment of healing too. Just the body knows how to heal things. We just have to try to help it. So I think overall, helping understand that we're trying to get things to grow together and see if we can augment and learning from it as well. I think probably instead of more of the biologics that are there, that may be more of a setting for if you have more just what's called wear and tear tendinopathy of that Achilles as well. Using things like PRP, there's nothing that I know of that's really earth-shattering in terms of, hey, this is going to fix your problem with it. I think overall, in terms of trying to get things to heal better, it's probably just as much of an evolution of our surgical techniques as well for those things. So for me, what works best in my hand is actually something that tries to minimize some of those downsides of the wound healing issues and the re-rupture rate. So my preferred technique for doing a surgical repair in the majority of my patients is actually what's called a hybrid mid-substance repair. And so it's a smaller incision, usually about 3 to 4 centimeters, and there's usually a jig that we can introduce up inside the confines of the sheath around the tendon, and we pass suture through a percutaneous fashion. Then we take that down and actually deliver it and secure it into the heel bone itself with a combination of suture anchors. And so that avoids a couple of the things. One is that bulky, thick tissue that's there. So from the biological environment for healing, we're just trying to help organize it. You know, and the concept that we were trained to, and I imagine they probably use the same phrase when you were going through your courses as well, as you're doing gardening, you're not doing carpentry. And so we're trying to grow better quality of tissue as well.
And just telling the body where to do it.
Right, just trying to help organize it and let the body do its job. You know, we're designed in a remarkable fashion, just trying to make sure we can secure it and try to set that tension. And then, again, just counseling people on the recovery involved with it. But in my hands, I think what works better for me, like I was saying, is being able to organize it. There's less suture bulk. And the other thing, too, is there's no knots. And so when people are doing a traditional open repair, bigger incision, sometimes even, you know, 10, 11 centimeters.
I remember that in residency.
Yeah. And I've done them as well, you know, and this is part of that evolution as well. It's a very classical technique, and it's not a bad technique. It's just something that I think that has a couple of the negatives, that it's just more sutured, and the other thing is there's knots. You're relying on the knots that you tie to secure it, but people have also looked, too, when it comes to the strength and where it fails, it's going to fail to knot. And so if we can minimize that, secure it to the anchor, that's why I think it's worked well.
Is that jig, that kind of I tell Jim, it looks like you're stitching a baseball with that thing. Is it?
Yeah, they kind of
needles everywhere.
Right.
That's
It
pretty slick technology.
parts, yeah.
You know, compared to eyeballing it and just pulling and tying knots, like
Right.
you say. It's pretty interesting advances in your instrumentation.
Right.
So
Exactly.
makes the surgery more biologically normal, I would suspect, than what we do.
Sure.
Is it?
Before we get off orthobiologics, if you don't mind, we've got a couple of questions that have
Okay.
come in. Ross is wondering if PRP or stem cell are covered under insurance.
Not that I know of.
Not routinely. And most people too are basically responding in that similar fashion. You know, we'll ask our patients as well, you know, when they've gone maybe some other places just trying to learn, just making sure that we can help guide them for that as well. So I've not heard of it actually being covered underneath that.
I know that when Chris Anderson was with me talking about PRP injections for knee arthritis, it was very specific that they were not covered. Things may change, but really, frankly, it's going to take years of collecting good data before the insurance companies will be willing to fork over the money for that. Any other question?
We do have another question, unrelated, from Martin. He says he has pain running down the back of his leg and calf when he walks, and wondering if you have any advice on that.
Okay, well, is this from Martin, you said?
Martin, yep.
Martin, so a little bit more specific, sometimes pain down the back of your leg can be a lot of different things. It can be Achilles or calf related if it's below the knee.
It can be spine.
It can be spine, that's right. It can be sciatica or nerve pain coming down. It really kind of depends on the pattern, the location, the duration. So it's hard to say online what that might be, but it could be a variety of things. It could be hamstrings as well, depending on where you're talking about in your leg.
It could also be a blood vessel issue.
That's correct, yeah, a blood clot or something like that, or a blood flow issue.
I'd say probably from a recommendation standpoint, it's get an appointment with a provider and start from there, and really the combination of the exam and then also the discussion and the history of when it happens, what makes it better, what makes it worse, can really help guide where you go from there.
I absolutely agree, absolutely agree. So with that, let's wrap things up. What can somebody do to minimize the chance of injuring their Achilles complex, the
Sure.
whole calf and Achilles structure?
Gotcha. I would say listen to your body. If you talk about the majority of people that come in, they're not telling me that they have all this pain before. You know, if you say there's a classic history of what's called a prodrome, where you say, yeah, I had some achiness and some soreness when I was kind of pushing, doing those things, but honestly, the majority of my patients that I see, they don't really describe that. So to that point, I would say listen to your body. If it bothers you, make an appointment, be seen, and we can counsel and go from there. We can't predict ruptures, and I tell people often, I can't predict the future. I can't tell you if you're going to rupture it, but I can help give you at least a general sense of, should you live your life in fear? And the answer routinely is no, don't. And you know, don't let an Achilles tendon rupture fear keep you from trying to be fit and trying to be healthy. And if you have issues with it, we can certainly see you. Different things you can do to try to avoid it, primarily stretching, just trying to prevent that tight Achilles. Not that there's any direct relationship between stretching before an exercise, but really just more trying to avoid more of the contracture where the Achilles gets probably over tightened and then has too much tension, and then going from there. And then avoiding things like steroid injections. So steroid injections we use commonly through multiple different treatment options, otherwise known as cortisone shots, for example. That's just kind of a catch-all term. But probably the one place where I would not put one is right in the back of the Achilles. You don't want to weaken that. So if you see, hey, I'm having pain, don't have a cortisone shot put in the back of your Achilles, or it can really increase the risk potentially of doing that. But
how about the last thing that I've always been interested in ever since kind of residency medical school, the effect on certain antibiotics and tendons, particularly the Achilles tendon,
Sure.
since it's under such tension.
Right. So probably the number one bad actor when people talk about it, those antibiotics are a class of medicines called the fluoroquinolones. So ciprofloxacin, levofloxacin, moxifloxacin. And the way that those work, there's potential for it to affect that. And it's really all over the place. People will sometimes come in, they say, I tore my Achilles, but I had this medicine 3 years ago. And I can't say that's definitely cause related. Sometimes people have one, and a week later it starts bothering them as well. So there's an association that's well documented, but it doesn't mean you shouldn't take the antibiotics if it's prescribed, and if the pros and the cons are weighed by your provider who's prescribing that, whether it be your primary care or someone else as well. but it's something that it can happen. The same thing too for any kind of anabolic steroid, people who are doing bodybuilding, for example, patella tendon ruptures, quadriceps tendon ruptures, Achilles tendon ruptures as well. They're in association with it too.
Awesome, awesome. How would you like to finish? What would you like to say?
Sure. Well, if you have any questions or any concerns for really anything foot and ankle related for me or just any of my other partners as well, just make an appointment at TOA. We'd love to have you. I'd love to evaluate you and try to get you doing what you want to do as safely and effectively as possible.
Thanks so much. So he said it all. Go to TOA.com. You can learn about us. You can learn about, last thing, do you go to any other office besides the Murfreesboro?
Not me. I just stay here.
You're a
There's
home
plenty to
guy,
go around.
hometown crowd. So if you'd like to get an appointment with Dr. Thompson, go to TOA.com. You can learn about our offices, our practice, our locations. We're getting bigger and bigger to serve middle and further reaches of Middle Tennessee. So please go out there, stay healthy, be safe, stretch. Don't panic if you get hurt, and go out there and live your best life. Take care. Thanks a lot.